You have a great conference. It's a great honor for me to speak shortly about this topic. So we can say that this is also timing of emergent carotid endarterectomy in tandem occlusion strokes treated by thrombectomy. We know that since 2014, the acute stroke with the large vessel occlusion is treated by combination intravenous thrombolysis and mechanical thrombolysis. But the logistic is very difficult because after intravenous administration, we have to transport the patient to the central regional center with the non-stop angiography and mechanical removing. It's very effective, but logistic is very, very important. And we can see that in Europe, the blue color is good organization. There is a 50 patient per million. It's good organization. But the red color, you see that the number of the mechanical thrombolysis is still very low. So it should be improved. But it's a big future for the care of the patient with stroke. And we can see that some countries, they have many work for improve this, but we are lucky that in Czech Republic we have now with Germany very good care. It's because we have a small country and 10 million population, and all region has a specific organization with the intravenous thrombolysis, and then very quickly transportation to the central stroke center for mechanical thrombolysis. And especially in my area now, we reach 200 patients per million, which is like incidence of this stroke. So we are very lucky, and the care now is in this level. And for neurosurgeons, I think it's a new chance, because 10%, between 10-20% of this patient with acute stroke with the large vessel occlusion, they have parallel stenosis of the carotid, and this stenosis should be treated acutely. We think that it should be treated by neurosurgeon, because it's the same language with the neurologist and neuroradiologist. So typical case, 70-year-old male with the emergency right hemiparesis, and you can see the occlusion of the MCA left side, and parallel, the etiology of the stroke is stenosis of the carotid. So transportation to the central stroke center for the angiography, removing with the catheter the clot from the MCA, and nice flow. So it's a fantastic treatment. But now we have a residual stenosis of the carotid. What to do now? Operation or stenting? Stenting is problematic because the patient has no dual anti-aggregation. And this patient more was dependent on the high level of the blood pressure. So it was perfusion compromising. So it's an acute patient for this kind of carotid surgery. We always do diffusion weighted MRI to disclose the volume of the necrosis. If it is 30% of the territory MCA, we operate acutely. And we did surgery. Necrosis is the same, so no complications. And this is solution. So this is our pilot group. We evaluated these acute patients with this carotid surgery, and we disclosed that complications were in the very early surgery, between 2 and 6 hours and between 6 and 12 hours. So all complications were within the first 12 hours after mechanical thrombolysis, and therefore we conclude that we should exactly know the coagulation of the patient. So we do now rotational thromboelastometry. So coagulation, if it is good, we can operate acutely. If not, necessary is to wait and compensate the coagulatory pathology. So if we created algorithm for this problem, so very early surgery should be when there is severe stenosis and neurological stable, which is unstable, repeated TIA or some hemodynamic problems. And against it, we should be very afraid if there is a large ischemia and where is their coagulation disbalance. So if the patient has this problem, we wait and prolong the surgery, the timing of the surgery. So our algorithms is this. So we prefer the carotid surgery against the stenting. Timing is very important, and we consider always the neurosurgical status, diffusion, and coagulation. So it's very easy but very effective. And we think that this topic is good chance for neurosurgeons, because vascular surgeons are good, they have good experience, but it's a new topic, new communications. You should evaluate neurological status, diffusion, MRI, and so on. And I think it's a new chance for us. And short discussion with the neuroradiologist, why the carotid is better from our point of view. Because the experience and the opinion, it's not solid. Some say yes, stenting could be performed immediately after thrombectomy. Some authors say it's not possible. And we have also the registry, is also no consensus. And what is the problem? Problem that is there are 4 possibilities of the arrangement of the for stenosis, and all have some problems. First, acute stenting with antithrombotic agents intravenously administered, because the patient is not prepared before the stenting. Of course, it's acute patient. So some authors recommend intravenous ASA or intravenous some medication. But problem is the rate of symptomatic hematoma is 20%. It's high percentage of the problems. Second scenario, we can do stenting without any antithrombotic agents. It's also risky because there is a stent thrombosis as high as 27%. So it's also very high number of complications. Acute bowel angioplasty, it's next scenario, but it's not efficient because the 1 week stroke risk is 10% and occlusion rate is also high. So this angioplasty, it's not solution for this stenosis. And no intervention, also a possibility, but here is the risk very, very, very high. So we see that the stenting is very problematic, and acute carotid endarterectomy in the hands of the neurosurgeon should be strategy for this problem. We have three timing interval. If we have critical stenosis and patient has an unstable situation, crescendo transitor attack, so we can do this surgery very early, between 2 and 12 hours after thrombectomy. 2 hours it's okay because the half-life of the actilisa is very short. But this period is very risky. It should be indication in this unstable patient. The best timing for us, for our series, is between 12 and 24 hours. So to do the same day, but wait 12 hours, we have time for coagulation test, and we have time for everything prepared. And if we have a large ischemia or some coagulopathy, we wait, of course. We wait for normalization of the coagulopathy. And if there is a large ischemia on the diffusion or even some hemorrhagic signs, so of course we wait maybe 1 week, 2 weeks, according to severity of the stenosis. So thrombectomy in Europe, it will be better in all countries, I think. So it's a new topic, and we will treat minimally 20% per year of these patients in the future, because the thrombectomy and the care of the stroke, it's now growing. It's good organized. Shortly about the results, we did research of the literature, so you can see that not many papers are published because this topic is very fresh and very acute. We will now publish this set of 65 patients after thrombolysis and thrombectomy, and we had complications in the first 12 hours. You know it from the pilot group, and then we have 2 more problems even in the later surgery, but it was problem with the ICU care. The patients, they have hypotension. The blood pressure management is very important in this management. So we reach complications 7.7%, which is very acceptable comparing to problems with the stenting and comparing with the symptomatic stenosis, which is 6%, and this group of patients is much more risky for the management. But 7.7, I think it's very good number. And if we compare the results of our stenting, we had the 24% stent occlusion. So when we compare our risk against the risk of stenting, so in our hospital also we can confirm literature data that the carotid endarterectomy could be solution for this interesting problem. So conclusion, acute carotid endarterectomy after thrombectomy is acceptable risk of the complications from our set of patients. We reduced the risk of recurrent stroke. This is main philosophy of this surgery. To do is as soon as possible, safely, but we reduction the risk of the recurrent stroke. And operation is safer than stenting. Is good for discussion with our neurological friends, and for point of view of neurosurgery, prevention of the hypertension in ICU, it's very important because the patients are very unstable, usually old patients. So this is alpha omega of the good results. So future management of the tiny lesions I see is neurology. They seek all the countries in Europe very soon. They reach the same numbers. It's about 200 patients per million, and in Ukraine also it's a big number, and 20% of these patients, they will have a tandem lesion with carotid stenosis, and I think it's a good chance for the neurosurgeons also in Ukraine to care about these patients and start with carotid surgery, because it's very nice surgery. It's very frequent in our department. Is the most frequent surgery because we do every year about 150 cases per year. So thank you for your attention, and I pray success to your conference. Thank you.
Martin. Thank you for your good presentation. Fantastic. SIA neurosurgical procedure. It's very good. Would you please question to Martin? You have? Є якісь питання до Мартина? Будь ласка. Нема. Thank you, Martin. Thank you for you.
Thank you. Good luck. Thank you.
In this year, in September, we have 7 Congress of Ukrainian Neurosurgical Society in Odessa. Welcome to Odessa in September. Good time.
Yeah, great pleasure. Thank you very much.
Thank you.
I have never been in Odessa. It's exciting for me.
Okay. Nice day.
Nice day.
Bye. Thank you.